I want to get to my topic for the night, which is a case presentation of the child who has come to be known as the Mississippi baby. Many of you in this room are, I would not expect to be vastly familiar with the normal or common treatments that we give for babies who have been exposed to HIV. So I'm going to start by giving you just a few background sort of baseline things here. First thing, most of you know that HIV is a blood-borne illness. It's transmitted from person to person through either blood-to-blood contact or sexual contact, or from mother to her infant at the time of birth or during breastfeeding. HIV, when it enters the body, it infects cells that have a receptor on the surface of the cell called CD4. So CD4 positive cells. Now, many of those CD4 positive cells are T lymphocytes that are very active in our immune system. So it infects the activated T lymphocytes that are circulating in the blood and very rapidly starts replicating itself inside those activated T cells, and in the process it ends up destroying those activated T cells. It also infects, however, latent, or what we call resting T cells, and inside those resting or latent cells it does not replicate, but it can live for a very long time, as long as the cell lives, and many of those resting T cells can live for many years. So the virus stays alive and is replication competent. If the cell becomes active, then the HIV begins replicating within those T cells as well. As long as the cells are resting and the HIV is not replicating, those cells live for a long time, and we call that our HIV reservoir. And these T lymphocytes make up most of the HIV reservoir. Okay, as you all know, we have a number of therapies, a number of drugs that we use to treat HIV, and we can control HIV for a very long time with these antiretroviral drugs. But the drugs do not kill the HIV virus. They do not eliminate the virus from the body or from the cells. What they do, the effect of the drugs that we have available at this point in time, is that they simply control the replication. So they interrupt the replication cycle. And if we can do that, then the virus, of course, doesn't destroy the cells because it's not replicating within those activated T cells. And we can drive the amount of virus that's in the blood down to very low levels, below, in fact, the lower limit of the test that we have. So we call that undetectable virus. Doesn't mean that the patient no longer has virus. It simply means that it's lower than the level that our tests will read, and we can keep it there for very long periods of time. All right, prior to 1994, in resource-rich countries like ours and like yours, the rate of transmission from an infected mom to her infant ran somewhere close to 25%. In 1994, there was an analysis of the data coming from an ongoing study that showed that if the mom was treated with antiretroviral drugs during the pregnancy, and if the baby was then treated for the first 6 weeks of life, then the risk of transmission dropped precipitously from 25%. As years have gone and we've come up with better and better therapies, we've found that we now have the rate of transmission among treated women down at less than 2%. In the state of Mississippi, I looked recently at our data, and in the 13 years between January of 2000 to December of 2012, we had an overall transmission rate of 1.4% in our state, and that represented 8 infected babies during that 13-year period. All 8 of those were born to moms who did not have any therapy during pregnancy. So our transmission rate among treated women in the past 13 years has been actually 0% in Mississippi. That's something we're very proud of, and we worked very hard because we want it to remain 0 for many years to come. One other fact you need to keep in mind, the perinatal transmission from mother to infant, normally occurs during the labor and delivery process. And in a minority of cases, it may occur prior to the onset of labor, but probably within the last few days to weeks of the pregnancy. It rarely occurs any sooner than that. Okay, so now to my real topic. I'm going to tell you quickly just the story of the Mississippi baby. Okay, this baby was born in 2010. The mom did not have any prenatal care, and she therefore was not tested for HIV and did not know that she had HIV. When she presented in labor at a rural hospital in Mississippi, they did a rapid test, a rapid screening test, which came back positive. And this is something that we try to do on all moms. If we don't have firm evidence that they are not infected, then we test. And the screening test came back positive. Now, the screening test is not 100% confirmation that she's infected, but it was a pretty good indication that she was probably infected with HIV. She was too close to delivery to be able to do anything about treating the mom, so she delivered at that rural hospital with a vaginal delivery. The baby was a little bit preterm. It was labor onset at 35 weeks rather than the normal 37 to 40 weeks. And the baby was transferred then to our hospital in Jackson, to the University Medical Center nursery, because there were some concerns about some other issues with the baby, but also because that rural hospital did not have all of the antiretroviral medicines in formulations that could be given to infant. So the baby arrived at our hospital at close to 30 hours of age. We drew blood from the baby for virologic tests to find out if the baby had already been infected. And we started just the single drug that we normally use for treating babies who have been exposed to HIV. Within 30 minutes after the baby got to our hospital, we got back confirmatory testing on the mom that confirmed her infection status. And at that point, we started 2 other drugs as the last portion of our protocol to prevent HIV, which is called post-exposure prophylaxis. So this baby took the 3 drugs as post-exposure prophylaxis. At the end of the first week, I think it was day 5 and 6 of life, we got back the results of those tests that had been drawn at 30 hours. And both tests, there were 2 different types of tests, both virologic tests, so they were looking directly for the virus. Both tests came back positive. So that met the definition of infection, and I was very sad. I'd started the drugs hoping that we would be able to prevent infection in this baby. We had failed at that, but we kept the same drugs going because these were the same drugs that we could use as treatment in any infected baby. So the baby stayed on 3 drugs, went home from the nursery on 3 drugs, and these were being used as treatment for infection. Told the mom to begin with, she will need to be on antiretroviral drugs for the rest of her life. We think that if she stays on these antiretroviral drugs, if she does all the right things for her health care, she probably has a very good prognosis for a long, healthy life. And so the baby went home on medicine. We followed her very carefully during the first 19 days. I drew at different time points in those 19 days. I drew viral load measurements at 3 additional times when it came back positive. We saw a decline in the viral load that was biphasic, which is very typical of beginning treatment on an HIV-infected patient. And by 26 days of age, the viral load had dropped down to below the level of detection of our test. So that's exactly what we wanted to happen, exactly what we expected to happen with a baby on therapy. Over the next 12 months, I saw the baby in clinic once every month, and we tested her viral load every time, and it remained below the level of detection, just as we expected. I saw her again at 15 months of age and again at 18 months of age, and both times her viral load remained below the level of detection. Then she didn't come back for several appointments after that 18-month visit. We got to where we were unable to contact her mom by phone or by letter or any other way. We tried contacting the grandparents and they didn't know where she was. So we got our public health officials to start looking for the baby. They found the mom and the baby and brought her back into clinic at age 23 months. The mom told me when she came that she had quit giving the medicine at 18 months of age. So here we have an infected baby who was well treated to begin with, but at 18 months, or at least by 18 months, it probably occurred a bit earlier, the mom had quit giving the medicine. Now what has happened in every other case that I've seen or that anyone else has seen and reported is after the medicine is discontinued, a few weeks may pass, a few weeks at most, usually just a few days, and then if you measure a viral load, you'll see that it's come back. So I expected at that visit at 23 months to find a fairly high viral load and perhaps even some damage already occurring to the immune system. I scolded the mom and sent her home, not restarting the drugs yet because I wanted to test for viral resistance to the drugs that she had been taking. And it takes about 2 weeks to get results of that test. So I sent her home with an appointment to come back 2 weeks later when we would have results of that test and I would know what drugs to restart. Instead, when we got the results of the viral load, it came out undetectable. Now that was a big surprise to me, but the logical explanation for it was that probably the blood sample had been mislabeled or had been switched with someone else's in the lab. So I chalked it up to lab error. We called the baby back in, drew samples again for both a viral load and for 2 other tests for infection. And much to my surprise, all of those tests came back negative. At that point, I was very confused and didn't know what to do. So I called in the experts. I called a friend of mine who is a pediatric immunologist at the University of Massachusetts. Her name is Dr. Catherine Lazuriaga. And she called a friend of hers who is a pediatric virologist at Johns Hopkins University, and her name is Deborah Persaud. So the 3 of us started putting our thoughts together, trying to figure out exactly what had happened here and do the proper test to try to figure out what had happened. And we've been carried on from there. They did a lot of tests in their labs, and we sent some blood tests also to the National Institutes of Health labs and some of the other research labs that are located in California. And they did a number of ultrasensitive tests looking for the virus not only at very low levels in the blood circulating, but also looking for evidence of the virus inside some of those resting T cells, or the latent T cells that we call the long-term reservoir. And if you want to see the details of those tests, you can look at our paper, which has just recently been published in the New England Journal of Medicine. It's in the November 7th print edition and in the October 23rd online edition of New England Journal. So the details of those test results are there, but bottom line is we could not find any replication competent virus in any of the resting cells. We did cultures of resting cells and could not grow any replication competent virus in this child. So let me stop there with just the story and kind of back up and go through the story again, anticipating the first question that you're going to ask, which is going to be, which I anticipate would be, so what were you thinking? And that's a question that I've asked myself many times since March when we reported this case, as the cameras flash and I'm very uncomfortable in front of crowds. I keep thinking, so what was I thinking? But that's the question that we've been asked most commonly. So I'm going to go back. So what was I thinking when this baby arrived in my nursery? One of the questions that had to be asked is it reasonable to start more than one drug as post-exposure prophylaxis in a baby that we don't know is infected? Now we knew by the time we started 3 drugs, we knew that the baby was exposed, and we knew that it was a high-risk exposure. If I had known, and when I have, babies that are born to moms who have been on medicine throughout the pregnancy and they've controlled the virus very well, I know that those are low-risk exposures. Those babies have less than 2% chance of being infected. So for those babies, I do what everybody else in resource-rich countries do. I treat with one drug for 6 weeks, 4 to 6 weeks as post-exposure prophylaxis. And that drug is zidovudine, or commonly known as AZT. But this was a case where the baby was at higher than 1% risk. The baby was probably at 25% risk. There were some other small factors that probably raised her risk of infection a bit higher than the standard 25%. One of those being her prematurity, and one of them being the fact that she was delivered vaginally as opposed to cesarean section. And one of them being that the post-exposure prophylaxis was not actually started as early as we like. Generally, we start the post-exposure prophylaxis within the first few hours of age, and this baby didn't get to us until 30 hours, or nearly 30 hours. So with all those factors, I knew that I had a high-risk delivery. And with the high-risk exposures, it was not known during 2010 whether one drug was going to be most efficacious in preventing HIV infection, or whether 2 drugs might be better, or whether 3 drugs might be better than 2. There was an ongoing study at that time, the results of which later showed that 2 or 3 drugs is better than 1 at preventing HIV infection. And remember now, I was not even thinking about curing this baby. That had never entered my mind. My effort was to prevent HIV infection. I used my logic and the fact that when we have an exposure in an older person, a needle stick injury in my clinic with a contaminated needle, or a sexual exposure with sexual assault, we always use post-exposure prophylaxis in those cases using 3 drugs at treatment doses. So in my thought process is this was a high risk exposure, and using more than 1 drug was standard of care in other high risk exposures in older patients, and it seemed logical that we would use the same approach with these infants. So the next question that comes up is, well, what about the toxicity of using these drugs in an infant? And yes, there are toxicities of every drug from aspirin on up. We know, because we've used these drugs in infected children for years now, we know generally what the toxicities are, what to expect, and in most cases, those toxicities are very easy to monitor for. I can do a CBC, I can do liver function test, I can do renal function test, and tell if the baby is beginning to have toxicities from these drugs. Additionally, those toxicities are generally reversible. So if the baby begins to have any signs of toxicity that are getting over the line of what safety is, if we stop the drugs, then all of those parameters come back to normal. HIV, on the other hand, is not reversible. So I felt like the risk-benefit ratio that we always measure in our heads when we're about to prescribe medicines for anybody, that in this case, the benefit of giving the drugs and possibly stopping or preventing the HIV infection far outweighed the risk of giving the drugs. Talked to the mama on the phone and she agreed. So that's what I was thinking when we started those drugs. Now remember, I was thinking about preventing infection. I was not thinking about curing a child. Another one of the questions that I had, it was something that I was doing as a standard therapy in all high-risk exposures. And not only I, but many people across our country and in your country as well, were using multiple drug post-exposure prophylaxis for babies who are born at high risk of transmission. So another question that comes to mind is, if I use only zidovudine in this baby, or if I use only zidovudine plus 1 other drug, am I inviting viral resistance to 1 or more of those drugs if the prophylaxis fails? In other words, if this baby becomes infected despite my use of post-exposure prophylaxis, then will that baby end up with a lifetime of living with a virus that's already resistant to some of the very few drugs that we have for treating infants? And 2 of the 3 drugs that I was using as post-exposure prophylaxis are ones that we really need to be able to treat throughout infancy, and they have very low barriers to resistance, meaning that at a single point mutation can occur that will create viral resistance to those 2 particular drugs. And that's not a situation that I don't want to have a baby that I've got to treat for the long term who already has resistance to 2 of the primary drugs that I need for treating that baby. So another good reason for using 3 drugs instead of just 1 or just 2 is that you lower the risk of viral resistance developing when you use combinations of drugs rather than 1 or 2 at a time. Okay, another one of the questions is what are appropriate doses for a baby born at 35 weeks gestation? Unfortunately, we still don't have really good data on the pharmacokinetics of any of these drugs in preterm infants other than the AZT. 35 weeks is close to term, and we probably would find, if we did very careful studies, that the other two drugs are metabolized pretty well at 35 weeks as they would be in a term baby. However, we really don't even have good data in term babies for one of these drugs. And so I had to do what pediatricians do very commonly, which is make a good educated guess. We educate ourselves on the mode of metabolism of each of the drugs, and then we know in preterm babies, kind of at any given gestational age, what we can expect as far as renal maturity and hepatic maturity, and how well they'll be able to metabolize drugs and eliminate drugs through those particular methods. So I made a good guess and went ahead treated. Okay, then when the test came back showing that the baby was infected, I was depressed, and all my team was depressed for a while because we really didn't want any more infected babies in Mississippi. But it was a good thing that we already had the baby on treatment doses of medicine, drew another viral load. The viral load had come down from the initial nearly 20,000 down to 2,600. That's kind of what we expect on the first week of therapy. So in my mind, we were simply moving from post-exposure prophylaxis to treatment therapy. Through the first year of life, we saw the baby every month. This was a routine treatment of an perinatally infected child. Everything fairly routine for me. Very happy that her viral load remained undetectable throughout that time. And all of our other evidence was the mom was given the medicine appropriately. At 15 months, and again at 18 months, we saw the baby. And initially I had some questions because some of the labs came back indicating that maybe the mom was not giving all the medicine exactly properly. However, the baby's viral load remained undetectable, and I figured, why argue with success? If she's not giving the medicine, her viral load's going to go up. Hasn't every other baby I've ever seen, every other baby anybody else has ever seen. So as long as the virus remains undetectable, we're okay. Then after the 18-month visit, when she didn't return, I was firmly convinced that now the mom must not be giving the medicine properly. We called the pharmacy, got dispensing records, and found out they actually hadn't dispensed any medicine since age 15 months. So we knew that the baby was not getting the medicine properly. When she was found and brought back in at 23 months, I scolded the mother severely because I knew for a certain fact that the baby's viral load would have gone back up, and possibly she may have already been sustaining damage to the immune system. When that viral load came back negative, as I said before, I figured it must have been lab error. So we called the baby back in. When all of those tests came back negative, I was terribly, terribly confused. So called my friends in, and we started going through together, trying to figure out, okay, now what are our questions that we're going to ask ourselves and try to answer for ourselves. The first one was, what was the evidence that the baby was indeed infected to begin with? And we looked back, we had 5 positive virologic tests before the viral load got down to undetectable levels. By our definitions, a baby is infected if you have 2 positive virologic tests on 2 separate samples. So we had 5 that went beyond what our definitions require, and beyond that, her viral load had come down in the classic biphasic decline that we expect for a baby on therapy. Okay, our next question that we ask ourselves, okay, is this infection indeed with HIV type 1, and what subtype is it? Because our tests measure type 1 and they measure subtype B or clade B, which is the most common subtype in the West. They measure those very efficiently. They sometimes will pick up a little bit of HIV type 2 or other subtypes, but they don't measure those as consistently. So we went back to the mother's virus, and she had had a genotyping done on her virus when the baby was 2 weeks old, and that showed it to be HIV-1 and clade B, which is the common virus that we expect in the United States. So we also wanted to look and see if for some reason this virus was simply not very virulent, an attenuated virus for some reason. Viruses that are resistant to many drugs, if they've mutated to become resistant to many of our antiretroviral drugs, they often are actually attenuated or not as virulent as the wild-type the wild-type virus. So we took some of the mother's blood, tested the virulence of the virus, and it was very similar to our standard wild-type laboratory strain of HIV. It also had no drug resistant. So, kind of answer that question. Our next question was, does the child and or the mother have a very uncommon mutation which makes the T cells not have the CD4 receptor on the T cells? So people who are homozygous for what we call the CCR5 delta 32 mutation, those people are relatively resistant to HIV infection. So we did the CCR5 delta 32 test on both the mother and the baby. Neither one of them had that mutation. We also have a small subset of patients who are infected that we call elite controllers. These are people whose immune systems are able to control the virus to very low levels despite being infected. We tested both mother and baby for the HLA haplotypes that are common in elite controllers, and they had none of those. And so our next question was, could this be a functional cure? And when Drs. Lazuriaga and Prasad started using that word, which cure has been kind of a 4-letter word in the HIV world for a number of years now, when they started saying, could this be a functional cure, made me kind of nervous, because we have been thinking for many years that cure was not possible. It's only re-entered our vocabulary in the last couple of years, and there has been, that we know of, only one patient who has been cured of HIV. That is a patient known as the Berlin patient. He's an adult who required a bone marrow transplant for leukemia, and they used some of these CCR5 delta 32 mutation cells as the stem cells to replace his bone marrow, and it has resulted in the fact that he, we think, is cured of HIV. He's not been on medicines now for about 5 or 6 years and has not had a return of his virus. If we call this a functional cure in this baby, then this would be the first reported case of a functional cure in the baby. So we started thinking, okay, if this is a functional cure in this baby, why did it happen? And is it possible that it could be done for other babies? Our hypothesis at this point, and it is totally an unproven hypothesis, is that by treating the baby aggressively and very early, within the first 48 hours of life, we may have been able to prevent the infection of those latent T cells, or the infection getting into what becomes the long-term reservoir. Fortunately, babies, fortunately or unfortunately in various cases, but in this particular case, babies are not born with resting T cells. Those resting T cells are what we call T memory cells. They are cells that form when you're presented with an antigen. And since babies have not yet been presented with antigens, they are not born with T memory cells. As soon as they're born and they're suddenly coming in contact with various viruses and bacteria, they begin forming their T cells. But possibly what happened is we started treating the virus and got the virus down to quit replicating before it had a chance to infect any of the T memory cells that this baby began forming. And now we would like to test that hypothesis and see if it can be done in other babies and have a similar outcome. So the plan is that there will be a prospective study starting hopefully within the early months of 2014 at least, that will enroll high-risk exposure babies. They will be treated within the first 48 hours of life with triple drug therapy as post-exposure prophylaxis. They will later be tested to see if they are infected despite the post-exposure prophylaxis. If they are infected, they will be continued on therapy for 2 to 3 years. Then they will be tested with all of these ultrasensitive tests to see if there is replication competent virus in those long-term reservoirs. If none is detected, then their medicines will be stopped to see what happens. What we're hoping is that those babies will not have rebound viremia and will have a similar outcome to this baby.